Okay, so good evening, everyone. We have today's webinar on lumbosacral spine and hip musculoskeletal examination. Myself, Dr. Dimple Modi, will be studying. We will have a quick review on how to examine your lumbosacral spine and hip within 20 minutes of examination, because examination is a very important part and we usually don't, many therapists don't examine properly. And because of that, we end up with a wrong treatment plan. So before starting with a good, proper treatment plan, we have to examine, so what kind of pathology the patient is suffering from. Sorry for the interruption. Actually, I have to admit the people who are joining. Okay. If you will hear clearly and will pay attention, you will remind everything. Within minutes, you will be examining everything in your clinical setup. So first examination is the thoracolumbar spine flexion. In this, what we have to do? Okay, let me give you some small introduction why we examine and what is the importance of the examination. So any pathology at the back or hip may have significant consequences, including pain and abnormalities of the posture and gait. Okay, so while considering any back pathology, what practitioner should do, he will examine everything by region to region, like cervical, thoracic, lumbar and sacral, because whenever there is a back pain, we don't directly go for the back examination. We always have little bit examination of the cervical and thorax level also, and we try to identify what is the source of dysfunction. Maybe it is a musculoskeletal or neurogenic or discogenic or arthrogenic. So localizing the pain generator is a very important key to make a proper appropriate treatment plan. So keeping in mind with this, all this examination, what we'll study today, we have to inspect the patient very nicely and clear. With every particular segment, we have to examine the patient, because it will help in you to plan a correct and a proper treatment plan. Okay, just patient is having back pain and you go with the SWD or IFT or ultrasound, that doesn't make sense. You'll not be able to identify the what's the reason behind. Is it a discogenic pain or arthrogenic pain or something other? So with this keeping in mind, with all these points keeping in mind, we have to have a proper examination. So whenever we start with that examination, what you have to do? You have to make the patient stand looking at the back, look for the symmetry. Okay, any pelvic tilt or something like that, any curvature, there is a scoliosis or exaggerated lordosis or kyphosis. Okay, then ask the patient to bend, how he's able to bend. Is he flexing his knee? Okay, he's in full extension, he's able to bend his spine or not. Okay, is extended movements. Is there any restricted movements, or there is a degree of what kind of degree of movement is at the thoracic and lumbar level, the sacrum and the pelvis? Okay, all please. Please mute yourself, everybody. Okay, so all these things we have to keep it in mind. Okay, while leaning, the level of iliac crest, the pelvic tilt, the lordosis and the kyphosis, the muscle bulk. Okay, all these things we have to see. The buttock, the any atrophy is there or not. All these points we have to note it down. Okay, this will be a proper your examination. You will observe, and the palpation is different while palpating the spine area. Okay, where it is there any scar or any operative history? Those also points you have to see. Okay, is there any scar formation? Is there that scar giving you any trigger point? Okay, the bony landmarks. Okay, properly you have to see. And after this, you have to have proper test. Okay, so this test we will see now one by one. Okay, so we'll go. So first test is the thoracolumbar spine flexion. In this, what you have to do? You have to ask the patient to stand in extension, maximally flex the trunk forward at the hip and lumbosacral region, and see how is the thoracopelvic rhythm. Okay, and see, check the quality, location, and the degree of pain. So normally 0 to 100 degree of the movement should be there, or the patient will be able to touch his toes. Okay. Okay, then second test is the spine extension and rotation. This the patient will stand upright and the examiner keeps the knee straight and extends the thoracolumbar spine area. So while the examiner will sit on the stool and will lock the knee so that the patient doesn't do any knee flexion. Okay, and the one hand of the therapist will be on the anterior shoulder of the patient. So it will help the patients to guide the proper extension movement. Okay, and you have to check you can check the oblique rotations also. Okay, and so the extension will be from 0 to 30 degree or 0 to 20 degree will be the rotations of the lumbar spine. So this degree of rotation also you should note it down while examining. Okay, then lateral bending, you have to, patient will sit and the knee will be pulled back to the edge of the table to decrease the pelvic motion, and the pelvis should not move while sitting, and the arm should be crossed on chest. Okay, and the stand behind the patient. Well, the examiner will stand behind the patient, and one hand is on the patient's shoulders and the other is on the contralateral iliac crest. Why? Because the patient will not, otherwise the patient will lift the pelvis up, and check the right and left lateral bending of the patient, and accordingly move your hand while doing your right lateral bending or left lateral bending. So one hand of which is on the iliac crest. So normal range will be 30 degree. Okay, flexion, extension, and the rotations. The hip internal rotation. Patient lie on the table with buttocks and hip. Okay. Okay. Hold the patient hip flexed at 90 degree and knee flexed at 90 degree, and internally rotate the thigh by swinging the foot laterally. Okay. So normal range will be 0 to 40 degree. Note this point that in degenerative diseases of the hip, the loss of internal rotation usually occurs before the loss of the external rotation. Okay, so internal rotation range is lost first as compared to external rotation if there is any degenerative disease of the hip. And avoid, while doing this test, avoid any motion of the contralateral hip or pelvis. External rotation, in this you have to externally rotate the hip by swinging the foot medially. Okay, so the normal range will be 0 to 60 degree. And in this same case, you have to keep it in mind that the contralateral hip or pelvis should not move. Okay, this way. Passive internal rotation and the passive external rotation. Then the hip flexion, patient lies supine on the examining table. Okay, actively flex the hip by bringing the flexed knee close to the patient's chest. Okay, so the normal range will be 0 to 125 degree. Okay, if the this point, if the hip flexion is limited with knee extension but improves with knee flexion, this may indicate tight hamstrings. Okay, and avoid cause any pain or excessive posterior directed force that can worsen the pathology. Okay, like this. You have to flex the knee. Hip extension, make the patient in sideline position. Passively bring hip into extension by placing one hand on the anterior thigh or knee, and the other hand on the iliac crest to stabilize the upper body. Okay, the normal range will be 0 to 30 degree. like this. And lumbar spine process examination, how you'll palpate, you have to check the bilateral iliac crest. When you will draw the line between connect the iliac crest of both the sides. You will find there will be either there will be midline between L4 or L5, or it will be the interspace bit of the L4 or L5, or there will be L4 spinous process. So this will help you to examine the upper and the downside of the spinous process. In this way, you will be able to examine the spinous process. This way, okay. The PSIS level, the iliac crest level will be L4, okay. And in this way, up and down, you will be able to examine. And other then comes the other test, lumbar facet grind test. In this, what you have to do, you have to stand with arms crossed across the chest, okay. Stand behind the patient. The therapist will stand behind the patient, extend the lumbar spine to 30° and laterally rotate, okay. Rotate laterally, right or left, and give the therapist will give the direct pressure, axial downward force on the spine, okay. So when there will be lumbar facet joint disease, if there is ipsilateral, if you are rotating towards right and you are giving axial pressure over this side and the patient is feeling pain, that means there is a lumbar facet joint dysfunction disease, okay. Like this, axial pressure you have to give vertically. There is another test called, wait, people are waiting. There is another test, Yeoman's test, okay. In this, patient has to lie prone with knee slightly flexed on the tested knee, okay. Stand behind the patient, grasping the ipsilateral distal anterior thigh with one hand, and stabilize the contralateral iliac crest on the other hand, and pull upward on the thigh, okay. Pull upward on thigh, bringing the hip into extension. So when you will bring the thigh into hip into extension, there will be pain in the sacroiliac joint. So it gives the idea about there may be a sacroiliac joint dysfunction, okay. And the examiner may change the placement of the hand over the sacrum or lumbosacral spine instead of iliac crest, okay. In this way, okay. Patient lying prone, one hand on the iliac crest and the other hand on the same distal thigh, and we bring it into extension movement, okay. So there may be, if there is pain in the sacroiliac joint, it shows that there will be sacroiliac joint dysfunction. Then the Gansley's test. In this, what you have to make the patient lie on the edge of the table so that the sacroiliac, just wait. You have to make the patient lie on the edge of the table so that the sacroiliac joint is on the table and the leg is outside the table, okay. And the patient ipsilateral buttock is partially off the table to place the sacroiliac joint at the edge of the table, okay. Stand at the side of the patient, gently push the knee downwards off the side of the table, okay. You have to gently push the knee downwards, okay. The examiner may need to push the contralateral knee into flexion to stabilize the knee. The other leg, which is already in flexion, which is touching the chest, you have to bend it more, bring it more closer to the chest, okay. If in this condition the pain there is a pain in the sacroiliac joint, that means it shows that the sacroiliac joint dysfunction or the facet dysfunction. In this way, okay. The red sign shows there you have to bring your knee more towards the chest, okay. And the green sign shows that you are putting the thigh into downward direction. And when pain occurs on the ipsilateral side, the hand which is on the green sign, it is showing, it shows there is a sacroiliac joint dysfunction or the facet joint dysfunction. Ober's test, everybody knows, lies on the side with downward thigh in maximal flexion, upward knee is flexed to the 90°, grasp the patient's ankle and passively abduct and extend the hip so that the thigh is in line with the trunk. Understood? You have to make the patient lie in side lying position, okay. Downward thigh is in maximal flexion, and the upward knee is flexed to 90 degree. Then what you have to do, you have to hold the ankle of the upward side of the upward, okay, and abduct it and extend the hip, so that is in line with the trunk, okay. And when you passively adduct and bring the thigh parallel to the midline, okay, either the patient will not be able to bring it in the midline, and so it indicates there may be tension in the tensor fascia lata or a IT bend. So it indicates the tightness of the muscle, okay, in this way.
Sure.
Noble's compression test. Lie on the contralateral side, the tested knee in the upward up position, flex to the 90 degree, place thumb over the IT band, over the lateral femoral condyle, okay. So you have to keep your thumb on the IT band, that is on the lateral femoral condyle, and passively flex and extend the knee, and also instruct the patient that you have to flex and extend the knee. So when the test is positive, when the knee is flexed from 90 degree to 0 degree, the patient will feel some pain in the 30 degree, okay. So that indicates it is a IT band syndrome. Okay, in this way. Fine. Now the straight leg raising test. Okay, what you have to do, you have to make the patient lie in the supine position, both the legs and pelvis in parallel. Okay, raise one leg slowly from 0 to 70 degree, while the other leg and pelvis remains parallel to the table. Okay, if the patient produces pain or numbness or which is radiating to the leg between 30 to 60 degree, okay, the range you remember, between 30 to 60 degree, okay, so that indicates it is a positive SLR, and SLR is always a passive maneuver. Don't tell patient that you raise your leg up. You have to keep your hand at the lower, at the ankle, and passively raise the leg, okay. And if the patient feels pain between 30 to 60 degree, it indicates it is a positive SLR. Non-radiating low back, buttock, hip pain is not consistent with positive test. So what it shows there is a sciatic nerve involvement, L5 and S1 root, irritation of the painful side, okay, with an angle less than 30 degree, okay. If there is a pain, it doesn't show that it is a positive SLR, because the nerve is not in that irritated position. There is already a slack in less than 30 degree, okay. So at the reproduction of symptoms, the examiner may flex the knee 10 to 20 degree if the patient is feeling pain. So what you have to do, you have to flex the knee to 10 to 20 degrees, so it releases the symptoms, okay. So we doesn't over aggravate the patient's symptoms, okay. And with this, if you add foot dorsiflexion, then it is called as the Braggett's test, okay. It is not called as then SLR, it is called as the Braggett's test. And what there is one more test in that, crossed straight leg rest test, which is also called as the reverse test. In this what happens when you raise the leg, okay. So the same leg doesn't have any pain while you're raising the leg. The other leg, which is on the table, okay, which is on the couch, shows symptoms, okay. The patient feels pains, okay, the radiating pain. It shows that it is a reverse straight leg cross test positive, okay. Ellis test, make the patient lie prone on the table, flex knee towards buttock. Examiner should be able to bring the heel within 4 degrees to 6 degrees of buttocks in females and 6 degree to 8 degrees in males, okay. Ipsilateral hip flexion during maneuver, okay, tight or contracted. It shows tight or contracted rectus femoris, okay. If there is a hip flexion occurring while you are bending the, while bringing the heel toward touching towards the buttocks, and if there is a flexion at the hip, okay, so it shows there is a tightness, okay. Slump test. In this, what you have to do, you have to make the patient sit, okay, on a table or a chair, okay, vertically so that the pelvis is in vertical position, but slumped into flexion while the legs are hanging off the side. Gently place hand on the patient's neck, directing the cervical and the trunk into full flexion. Bring the upper body down in flexion position. Okay, and the pressure should be very gentle. Okay, grasp the, then what you have to do in the next stage, you have to grasp the patient's ankle, passively move the hip into 90 degree of flexion and knee. Okay, and dorsiflex the patient's ankle. Okay, so for what you have to do, we have first bend the upper body, and then we have raised the leg up, and then we have dorsiflex the ankle. Okay, raise the leg up to 90 degree of flexion of the hip, and then we have dorsiflex the patient's ankle. If there is a reproduction of pain into lower back or lower extremity, okay, so that is a positive test. And positive test, again, how you can confirm? When you pain should resolve when you bring the cervical and the upper body in upright position. Okay, so that is when you sciatic nerve irritation or radiculitis in this. Okay, as the upper body, and then the raise the leg to 90 degree, and then dorsiflex the ankle. Femoral nerve stretch test. Make the patient lie prone on the table with knee flexed. Extend the patient's hip while maintaining the knee flexion. When the knee is flexed, you have to extend the patient's hip. Okay, so when you extend the patient's hip, there will be pain or numbness in the anterior thigh. You are stretching, na? When you are bringing the upper thigh, the leg, upper thigh upward position, extending to the at hip, extension at the hip. So there will be pain or numbness in the anterior thigh. So it shows there is a hip joint pain or femoral nerve irritation or lumbar radiculopathy. Like this, you have to extend it up. Limb length discrepancy. So you have to use the measuring tape, and you have to measure from the anterior superior iliac spine, okay, to the medial malleolus. Okay, so positive is when there is a greater than 5 mm of difference between both the limbs. Okay, you have to examine both the limbs in this. Okay, and other one thing you can also note it down, you can also measure from GT to lateral or medial malleolus. Another test is the femoral anteversion test. In this, what you have to do, make the patient lie on the with knee flexed to 90 degree. Okay, you have to make the patient lie in prone position, knee flexed to 90 degree, legs in neutral internal and external rotation. Okay, so there should be no internal rotation also and no external rotation also. So when you will place your hand on the lateral thigh over the GT, okay, the examiner rotates the hip until the GT is positioned parallel to the table. Okay, let me give you a, okay, in one first figure, what you can see, it is in straight line, and when you will rotate it outside or internally, okay, so this angle you have to measure, this angle. Okay, the GT is coming parallel to the table. Okay, so average for men, okay, for average it is 8 degree for men and for 14 degree for women. Okay, it decreases throughout aging until skeletal maturity. Okay, then Hoover's sign. Make the patient lie supine on the table, cup both heels in hands. Okay, ask the patient to raise one leg. Okay, when you will ask the patient to raise one leg, what will happen? If the patient does not extend the opposite limb, if the patient does not extend the opposite limb but put pressure on the examiner's contralateral hand, the patient may not be applying a full effort to lift the leg. So it shows there is a poor patient compliance performing the examination. Okay, so these are all the tests. Anyone having doubt in all these tests? All these tests are very important. 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 All these tests are very Does anyone having
हेलो
doubt? Yes,
मैम आईटी सिंड्रोम का एक बार और बता दीजिएगा।
IT syndrome. Okay. IT syndrome. How we will to test that? This is a noble compression test. I'll tell you the figure. Okay. Okay. In this, what you have to make the patient lie in sideline position. Okay. So the knee will be flexed in 90-degree. Okay. Then you have to, one hand is on the ankle and one is on the lateral malleolus. Okay. Then you have to make the patient do flexion and extension from 90-degree. Okay. From 90-degree to 30-degree, 60-degree to 0-degree. Okay. So when there is a pain in the 30-degree, okay, when the patients feel pain at the 30-degree, that shows there is a IT band syndrome. Okay. Lies on the contralateral side with tested knee up and flex to 90-degree. Okay. Then we have to make the patient passively flex and extend, and also you have to instruct the patient to extend and flex the knee. Okay. So when there is a pain at the 30-degree, that shows that the IT band syndrome. Okay. Any other test you want me to repeat? We have 10 minutes more. Anyone? Okay.
मैम व्हेन पेशेंट हैव कंप्लेनिंग अबाउट एमटीएसएस medial tibial stress syndrome, तो हाउ टू डिफरेंशिएट
Actually, I'm not able
iliotibial
to
band
hear you.
syndrome and
Ankit, I am not able to hear you.
मैम अगर पेशेंट को एमटीएसएस की प्रॉब्लम है, मीडियल टिबियल स्ट्रेस सिंड्रोम, और हम उसे टेस्ट कर रहे हैं, तो मैम उससे हम कैसे डिफरेंशिएट करेंगे दोनों?
जस्ट आप मुझे चैट बॉक्स में लिखेंगे, क्योंकि आपका साउंड बहुत इको हो रहा है. माय साउंड इज क्लियर टू यू एवरीबॉडी?
Yes, ma'am.
Yes, ma'am.
But why your sound, hello, everybody's sound is getting echoed. Okay. Okay, who asked me the question? Can you please keep it in chat box? Okay. So I'll finish up with this modified test. Okay, is it okay? Okay, so we come with the modified test. First is the thoracic rotation. In this, how you have to make the patient sit. Okay, the therapist will be behind the patient, and the patient will hold like this across the chest. Okay, and then you have to make the patient move right and left. Okay, so rotation you have to do. So if there is less than 45-degree, okay, the patient is not able to rotate. If it is less than 45-degree, it shows there is a thoracic or lumbar joint restriction. Restriction may be in the ribs also, disc also, or facet joint also. Okay. Next is the Thomas test. The Thomas test, the Ganslin's test, the Ellis, sorry. The Thomas test, Ganslin's test, Ellis test, femoral nerve stretch test. Okay, all these are in the one position. Okay, in one position in the cell. If this modified test, why I have mentioned in this particularly, because these are called as the fast test. Within 3 minutes, you will be able to identify much of the things what you want to see in the patient. Okay, so in order to change the position of the patient again and again, we will be able to do in one position only. Okay, so first we have done the test in sitting position. Then we are doing the other test. The other 4 tests we are doing the patient in the supine position. And the position of the patient will be how in supine, the half of the body should be outside the couch, so that the sacrum area is on the table. Okay, and legs are outside the table. Okay, fine. Thomas test. Okay, lie on the back with buttocks at a very end of the remaining examining table, with sacroiliac joint just proximal to the edge. The contralateral hip and knee are maximally flexed. Okay, with the patient holding thigh close to the body. Okay, and observe the hip and stabilize the leg if needed. Okay, you have to observe if there is any degree of flexion you are seeing at the hip or the associated lumbosacral lordosis. It shows that there may be a tight iliopsoas muscle tightness, or there may be tight Y ligament of Bigelow, or hip flexion contraction. Okay, then the modified Ganslin's test. Same as the position we have attained in the Thomas test. In this, what you have to do? You have to stand at the patient side and push the knee down. Okay, in the extension. So the hip will go into the extension. Okay, so when you will bring the hip into extension position, and so if there is a pain at the sacroiliac joint on the same side, okay, so it shows as the sacroiliac joint dysfunction. Then the Ellis test, same position, patient lying, okay, with the hip in the neutral position, flex the knee to 90 degree. Okay, when you will flex the knee to 90 degree, what will happen? The ipsilateral hip will flex. There you will see little bit of ipsilateral hip flexion. Okay, so if there is a ipsilateral hip flexion, it shows there may be a tight or contracted rectus femoris muscle or a hip flexion contracture. Okay, then modified femoral nerve stress test. Same test what we same position what we have attained above. Okay, so in this what you have to do? In this you have to flex the knee to 90 degree and apply pressure on the anterior thigh. Okay, so when will you apply the pressure at the anterior thigh, what will happen? There will be a sharp or electric shock like pain. Okay, so it shows that there is a femoral nerve irritation. Then the Ober's test. Ober's, in this also the same position what we have attained above in the above test. In this what you have to do? You have to bring the hip into neutral and attempt to abduct the hip parallel to the midline. Okay, so you have to abduct and bring the hip to the parallel to the midline. So what will when it will be the positive test? In the positive will show the thigh is not able to adduct. The thigh is not able to adduct in the midline without hip flexion. So this shows that there may be a tensor fascial lata tightness or iliotibial band tightness. Okay. Hip range of motion test. In this, what you have to do? You have to examine the internal rotation, the external rotation. That I have already told you. The external rotation should be till 45 degree. Okay, and the internal rotation should be about 20 degree. Okay, so in this you have to make the patient lie supine, and you have to flex the hip and knee to 90-90 positions, and you have to internally rotate and externally rotate. Okay, then we have seen the straight leg erect. Also I have explained you SLR test, and the last is the Faber's test or the Patrick's test. Okay, in this what you have to do? You have to make the patient lie supine. Okay, with the ipsilateral heel touching the other leg in the position of the 4. Okay, you have heard about this Faber's test. In the position of 4, you have to make the patient make the position. Okay, so in position of 4 indicates there is a flexion, abduction, external rotation, and extension at the hip. Okay, so when you apply downward force, at the and extend the hip, there is a reproduction of the pain. Okay, on the contralateral SI joint or ipsilateral groin pain. Okay, positive test indicates two things: if there is a pain at the contralateral sacroiliac joint or ipsilateral groin. Okay, so it shows that there is a sacroiliac joint dysfunction. Okay, or a hip pain, hip pathology. Fine. So the spelling also indicates there is all these motions. Okay, what movement you have to do at the hip joint? Okay, flexion, abduction, external rotation, and extension, and you have to press the knee in downward direction. So when you will press the knee in downward direction, so that the hip extension occurs. So there will be reproduction of the symptoms. Okay. So that's all. Finish I with my lumbosacral, spine and other test. Okay, let me see any questions.